Well, hello everybody. It's 9 o'clock, and this is the Institute of Health and Social Care Management, in partnership with the one and only Guy's and St Thomas's Hospital NHS Trust and the Royal Brompton and Harefield NHS Trust. My name is John Wilkes. I have the privilege of being the Chief Executive of the Institute of Health and Social Care Management. But today is not really about the Institute. Today is really all about what Guy's at St Thomas's and Royal Brompton and Harefield have been up to in the area of data-led prioritisation. And the good news for all of you tuned in today, well, two pieces of good news. First of all, number one, the temperature has now dropped where I live below 30 degrees, so the tie is back on. And secondly, I'm not going to be the chair today. The one and only Dagny Rajasingham is going to be chair. And Dagny, I'm going to hand straight over to you, if I may, for you to introduce Janaka and Mark. Thank you.
Thank you, John. There is apologies. Good morning, everyone, and a very warm welcome. Can you hear me all right? There is a bit of background noise, which will stop in a second. My apologies. I was on call for obstetrics yesterday, day and night, and I've been in for most of the night. My name's Dagny Rajasingham. I'm Deputy Chief Medical Officer at Guy's and St Thomas's. I am also a jobbing obstetrician clinically. And we would like to share with you the story of data-led prioritisation in outpatients with long-term conditions. I have been the Senior Responsible Officer for this project, this partnership with Factor 50, Guy's and St Thomas's, and within Guy's and St Thomas's City, which is our Centre for Innovation, Transformation and Improvement. And I'm going to get Mark to introduce himself because this noise is continuing. It will go off in a second. Mark, could I get you to introduce yourself, and then I'll come to you, Janaka.
Yeah, hi, good morning, everyone. Thanks so much for the invite, John and Jade. My name's Mark Hawkins. I run a small team called Factor 50. We're based up in Nottingham, but we've been partnering with Guy's at St Thomas's for nearly 2 years on this project. Really excited to share that story with you today, and we are looking for our next partners. So a little bit of a plug from me, but if any of this resonates with you over the next hour, then do get in touch. Many thanks.
Thank you very much, Mark. And Janaka.
Good morning, everyone. I'm Janaka Karalidi. I'm a diabetes consultant. My focus is in diabetes complications and also research in that area. And I've been working with Mark, Dagny, and the amazing City team on this project for the last 2 years. So good morning, and look forward to the session.
Thank you very much. So Janaka is going to be driving the slides. Janaka, shall I just give the very early intro, and then we will together do a little bit of presentation, an introduction, and then a presentation on the project. And I think what would be good to keep it interactive during the session. If you do have questions, please do pop them into the chat. John, Jade and I will keep an eye on it. But if you're bursting to know something, then just put your hand up and we will come to you. I'll keep an eye on that. The aim of the session is really to keep it as interactive as possible. So during the Omicron wave, you will all have heard that we've now gone into our fifth COVID vaccination programme. So this time during the Omicron wave, Factor 50 approached Guy's and St Thomas's because they didn't have a lot of work on at the time because of COVID, and they wanted to help us out. I was at that time running our trust response to COVID and COVID deployment. And when I was asked what problem could a health analytics company help us with, prioritisation of all those patients who would have to be cancelled, thousands and thousands of patients who'd have to be cancelled, either around ambulatory care. And when I say ambulatory care, I'm talking about scheduled but outpatient care, and those for elective surgery I knew was a growing problem, and one that was growing globally, actually. So we're not the only people who are having issues as a system of keeping up with patients who have been delayed and some patients who've been repetitively delayed. For those of you, and I'm assuming all of you work in the UK, we obviously have now had a series of industrial action for various clinical professional groups, and therefore this issue of cancellation and delay has continued to compound our issues with capacity across the system. So the initial approach was to diabetes, and we may come to the reason diabetes was chosen, but probably later, because I'm going to come back to Mark and Janica and ask them about what one of the highlights of this project has been and what some of the challenges have been. But I went to diabetes, and the clinical director of diabetes just grasped this, put me in touch with Janica, and then the rest really is history. I'm going to hand over to Janica, but just to say, as an overarching thing, what we have developed is a digital approach to prioritising waiting lists. We just, if you ignore the P1 to P5, because I suspect there are many of you on the call, and P1 to P4 certainly will mean different things. If you just focus on the colour, red being the highest risk, green being the lowest risk, and we're moving into super greens and super reds or infrareds. This is done with a set of clinical rule sets, and I'm now going to hand over to Janica.
Thank you, Dagny. So as Dagny put it very nicely, there's this large number of people waiting for appointments, appointments being cancelled. There's this hidden risk, which we as clinicians are unaware of. So the backlog, even before the pandemic, was significant. And these are risks that obviously have been highlighted since the pandemic. So what we know is that when we went through the first and second waves, I deal with transplant patients, for example, dialysis patients, manually going through lists to prioritize it is just not feasible. It's impractical, it's time onerous, and also it's inconsistent with a huge amount of subjectivity driven partly by clinical bias, but also other factors. So what we developed was a rule set where people trigger a red flag if they hit one of these 6 flags, which are all collected as part of routine care. So these are not extra blood tests, these are not extra visits, these are simple blood tests that we do in routine practice. And the way we approached this is, since a patient was seen at their last visit, have they had new data which will trigger one of these red alerts? If they've had new data, is it a red alert signal? Is it ambiguous? Is it data that is very stable and not concerning, things that haven't changed since previous values? And using the data we collect as part of routine care from the data warehouse, we created these color-coded risks. We use the P1 approach partly because of familiarity in the surgical setting, but the colors tell you in terms of new risk. So this is a new risk that has occurred since the last clinic appointment, with the data highlighting that risk, or stable risk, or very, very stable disease, which goes down to the P4 or P5, which may be suitable for a less intensive follow-up and also aid our prioritization of clinic lists. Next slide, please. So we've done a pilot. We chose those highest risk people, and we wanted to see, bringing them in, does it actually make a difference? They may have red flags, but can we modify the risk? The whole concept is modifiable risk. Is there factors that we can actually change? And what we observed in our initial pilot was that more than 40% of people had modifiable risk where we could actually intervene. So bringing the red flag patients forward made sense. We could intervene, prevent harm. It was also more time efficient. It was also saving a lot of money for the patients as well, in terms of avoiding unnecessary travel for those who have stable risk. We did a validation where we assumed clinicians were the gold standard, and the digital approach using the informatic approach or data provided a sensitivity of over 85%, suggesting this was as good as clinicians, but also a lot quicker in terms of, rather than a clinician manually using multiple screens and multiple data sources to assess risk, this saved 3 to 4 minutes per patient by actually having an automated digital approach to prioritize and stratify. And obviously we had positive feedback from patients as well as the admin staff who really appreciated a more objective standardized process of actually allocating patients. Next slide, please. So what we actually do is currently we have patients who score red, and we have patients who score green, if you like, or super green. And what we do is approaching a system where we prioritize the red flag patients by giving them green flag slots, if you like, and moving the patients who have stable data backwards. That's the long-term vision. In a day-to-day practice, we're now doing this digital approach for people who do not attend, so we can rebook those at highest risk first. When clinics are cancelled expectedly or unexpectedly, we've been cancelling clinics for years in many, many outpatient services with just people being booked kind of ad hoc. So we now have a more objective, focused approach where clinic lists, when they're cancelled for whatever circumstances, we run the algorithm, identify those people at the highest risk, and ensure that they are prioritized when we rebook the appointment. In parallel, as we will see very shortly, we can actually use the data to see, are we following the rules ourselves in terms of care processes and care pathways? So if we assume someone with stable long-term chronic disease may need to be seen once or twice a year in a hospital setting, are we indeed following that outpatient model, and are we adhering to processes and protocols? And the data-led approach also guides us in terms of checking this, but also identifying gaps in our practice, which audits, for example, may not always pick up because of the large volume data approach we do in this using this strategy. Next slide, please. So I'll pass over to Mark, but this was some really nice work that we did with Factor 50, and we wanted a simple tool that our admin staff, who are really the people running this behind the scenes in terms of rebooking appointments, we wanted them to have an insight, but also shared kind of co-design, which I think is really important, getting their feedback. So I'll hand over to Mark, where the admin can look at the reds and the greens and how the dashboard guides prioritization for the right patient to be seen in the right clinic in the right time frame. Mark.
Yeah, thanks, Janica. And so just briefly in terms of what's happening behind the scenes, we're looking at data from across the trust. We'll come on to extra data that we're building into the platform, but we're essentially, to start with, looking across the trust for all the relevant data that we can find on those patients. And then being clinically led by Janica and his peers to sort of set the direction, set the rules. We've then taken that away and coded that up. So the role that Factor 50 has played has essentially been sort of analytical partners, and then we've built the scoring platform. And so whether we quite need it daily, we're not sure, but we are running it daily right now. So we're refreshing the data. When Janica talks about sort of saving time, we're scoring, depending on how you define the cohort, 5,000 to 10,000 diabetes patients every day, and we're scoring them on the very latest data, including whether they've been to A&E the day before for a diabetes-related incident, or potentially they've had a blood test somewhere else in the trust, but there's relevant data. So that's why we're trying to keep it fresh and relevant. And then, of course, the challenge is we want to then present that back to the right people. So that's a team of admins and a team of clinicians, and just try and do that in a simple, straightforward way, but ideally also using the trust infrastructure. So the example on the slide here is a Power BI dashboard. We wouldn't necessarily always work in Power BI, but we've developed this in Power BI so that we can deliver it straight back really easily for the admins and clinicians. There's no extra logins, it's in the infrastructure that they're used to. But if we
Mark, work with sorry to interrupt, Mark, just for the benefit of people on the call who may not have the kind of clinical background that you would be familiar with in terms of using this dashboard, could you just quickly explain what the heck Power BI is for a start?
Excuse me, yeah, sorry.
And then quickly how this chart would be used by members of the clinical team.
Yeah, that's perfect, John. Thank you. So,
Mark, can I just interrupt then? I think it is absolutely lovely and really a result of this very successful partnership that you are now someone who is clinically informed and clinically literate, and that has been part of the beauty of this project. Apologies, but I just wanted to say that.
I'm not sure I'm clinically literate. In terms of this slide, essentially every week there's a number of different clinics, mornings, afternoons, different consultants, different types of complications, I guess, within different patient group. So there might be type 1, type 2, there might be, Janica can tell me all the different clinics, but some will be consultant-led, some will be nurse-led. And what we're able to do is profile all their patients, so it might be 5 to 10,000. And the reason I'm vague is like varies on how you define it. But then anyone within Janica's team, his peers, or the admins can look across the top and they can select. I'm in diabetes right now. We'll come to other specialties later in the presentation, but I'm in diabetes. I'm looking for a particular clinic. So next Wednesday afternoon's type 1 clinic. I'm going to use the filters across the top and I'm going to select all the patients in that clinic. And then all of the rows that you see on this dashboard are individual patients in those appointments across the clinics. And the little flags on the left, the little red or green flags, are the individual statuses of those patients, so that we can see, across those patients, some are red, some are green. And then if an admin needed to cancel a particular clinic, the bars across the top will start to give them a profile of which patients coming in a red, green, grey or amber. And so they can start to make informed choices. I'm thinking about cancelling next Wednesday's clinic. That's not a bad one to cancel because most of the patients are either green or grey. I'm thinking about cancelling next Monday afternoon's clinic. Hang on, there's a load of red patients, so I either need to hold on to that clinic, or if I have to cancel that for industrial action or something, then I'll prioritise the red patients when I rebook them. Thanks, John. And sorry, Power BI is just a tool. It's a bit like PowerPoint or Excel. It's a Microsoft product, but it's just a way to display data. And it's a tool that guys at St. Thomas use. So we've built essentially the display of the data in a way that they're familiar with.
Janica, there's a question about the clinical rules that defines what makes a patient red, amber and green, which you are going to cover. So Sandeep, we will come to that in some of the slides. And then if you still want to ask a question after that, we'll bring you in. Janica.
So yes, can we move to the next slide, and I'll make sure we cover that. So these are we're looking at type 1 diabetes here, and we've looked at as a model where it's also looking at opportunities to de-escalate follow-up, because we cannot see the red flag patients if we don't de-escalate the follow-up of the green or the super green kind of patients who have stable data, because we cannot create more capacity. We have to work within our existing resources, existing clinical staff, with all the challenges that we have now, but also likely in the future. So what we do is identify these patients on data. I'll just summarize the clinical rule set here, because I don't think we go into great depth later, but the clinical rules are new data since the last clinic appointment with HbA1c, which is our biological marker of glucose control. It's a 3-month average glucose control. It's what we use to assess our diabetes care and prevent complications. So if your HbA1c is rising, if your HbA1c is falling, we're looking at trends, but also absolute values, whether it hits a very high or very low HbA1c. We look at renal function, eGFR, which we collect in many blood tests. Renal function is a very important measure, because if someone's kidney function is falling rapidly, again, that means the patient is at high risk of many things, not just diabetes-related complications, but many other factors, and the patient is unwell. We're looking at hospitalizations, which have been coded to a diabetes-related emergency, attending A&E at St. Thomas's, or urgent care where high or low glucose or diabetes is anywhere in the problem list. And finally, we looked at diabetes eye treatment, because that's coded really well in terms of interventions, and it's the leading cause of working age adults going blind, diabetic eye disease. So if the patient is having treatment for their eyes, there is modifiability in terms of the risk factors that drive the progression of eye disease. And this is new data that has accrued since the last clinic appointment. And if this data triggers, you have a red flag, and if your data is stable, you go into your green or super green low risk category. Our current approach is that most people who are green or super green low risk should have once-year follow-up in our type 1 diabetes service. So we looked at our processes and we found that unfortunately we aren't all following the rules, and many patients are having more frequent follow-up. And this is going to have a knock-on effect, because if there are patients who score red, we won't have the capacity to see them promptly. So we have to ensure that the green patients are followed up appropriately in the safest manner, but also where they have access to attention if they do need it. Next slide, please. And what we can see is this patient-initiated follow-up approach, which all of us are familiar with, I hope, and is an important target. And it's a way of de-escalation, of identifying a group of patients who may have less intensive follow-up, but also allow us the capacity to see the red patients who are at more urgent need. And what we see here is that since we implemented a data-led approach where the clinicians have that dashboard similar to what Mark shared, where they see the reds and the greens and the super greens, since we've done that, we have now improved our patient-initiated follow-up to close to 20% or more, which is significantly greater than what we had in the past. So this is really a tangible what's happening now in our service. We are giving consultants and clinicians the confidence to move people to a less intensive follow-up pattern, but at the same time creating capacity to see those 2 or 3 red patients more promptly and more appropriately in the right clinic in the right time frame. Next slide, please. And I guess I'll pass on to Mark here. It's not just diabetes. The rule sets, as Dagny highlighted, are specific to one disease, but they can be adapted. And we have currently multiple specialties with long-term conditions having regular outpatient care who are following this. So over to you, Mark, for the next few slides.
Yeah, many thanks. So Janica and diabetes took the lead. Rheumatology is in second place if we think of this as a horse race. So we've been live with rheumatology for a number of months now. Rheumatology is slightly different. Rheumatology seems to be much more about the greens. So as we sort of work with each specialty, slightly different themes come out. Rheumatology has got a big PROMS element, so patient recorded outcome measure. So essentially how much pain a patient's in, how much discomfort, how are they living their lives. So PROMS features quite heavily in rheumatology. And rheumatology seems to be a bit more about sort of capacity creation. So they're flat out and some of their clinics are really, really busy, but we're able to identify similar sort of order of magnitude that Janica was just showing. So a big proportion of the appointments where patients look relatively stable. And we've also got great experience there of starting, so just back a slide, Jay. We've just got great experience of being able to actually reach out to patients and start to improve and learn about what sort of messages. And if you get in touch with patients and you explain, we've looked at some data on you, it looks like things are relatively stable. You know, are you happy to defer your next appointment, potentially not travel in, potentially not take an afternoon off work, pay for parking, all of that? We're seeing about 80% of patients saying, yep, that's great, I agree. And as long as you can see me when I need to be seen, that's fine. So in about 80% of the cases when we're talking to those, when the teams are talking to the patients are pretty happy to defer their appointment. And that creates the capacity to see news, which, by the way, the trusts get paid more for because they're on tariff, not on block, and frees up capacity to see the reds. So rheumatology is live. Renal and heart failure. Within cardiology, we're specialising in heart failure. And we've got the first set of criteria signed off there. And they'll be live pretty soon, loaded onto the platform pretty soon. And then ophthalmology and hepatology are close behind. Sorry, not so close behind, but we've started in those two. But just to flag, if other trusts had particular specialties they wanted to work with, if it was one of the ones that are at the top of this chart, we could move really fast. But if it's something, I was talking to a different trust last week, really care about haematology, we can absolutely work with them on haematology and take them through this process. But it's just going to take a bit of time because the rigor that Janica and his peers have put into it needs to be replicated. We need to get it right. We need to do all the clinical evaluation, which we've done along the way in these other specialties. But essentially, if you're a different trust wanting to do something like this, we can partner with you really fast on the specialties where we've done the learning already. We've done the evolution of the rule set and the testing. But if there's a different specialty you really wanted to work with us with, we can definitely do that. It's just going to take a bit more time, obviously, because you'd be starting at the beginning.
Mark, can I just come in there just to say that I don't know whether you and Janica would like to just elaborate a bit, and I'll contribute to that discussion around what it actually takes, so that there's obviously the clinical expertise, of not one clinician but many, and then there's the wraparound that we need to have. So maybe Mark, you could kick us off just on that little bit of off piece, and then Janica, if I could come to you from your clinical perspective, what made this project so successful? Because it isn't the first time people have been trying to do it, but we have done it at pace, with speed and accuracy.
Perfect. Sorry, the chat is distracting me. So would you mind just clarifying that question, Doug?
Yeah, it was to say, from your perspective as partners of us as a provider, what would you say are the 2 or 3 key things that have made us able to deliver on this project in the way that we have?
Yeah, no, brilliant. I think maybe 2 jump out. One's the clinical engagement side, one's maybe been the data support, the EDW side. So Janica and his peers have been great. They really care about it. Janica already had a bunch of these ideas in his head, before we sat down for the very first time. And so that turbocharged a lot of what we've done. But Janica and his team have been, really engaged, which has been brilliant. It's felt like we've been sort of inside the NHS rather than outside the NHS. And I guess part of that's also the city team. GSCT are lucky that they've got a dedicated team who can do a bunch of this. And one of the old members of their team joined the call. So, hey, Barty, nice to see you. Hope your new job's going okay. But the other piece has been the data warehouse piece. So we've partnered nicely with their data team. They've been pretty responsive. I think if we were to work with a new partner, we wouldn't need such a detailed integration because we know exactly what we're doing now. And it'd be a bit more of a case of sort of rolling it out, particularly in the specialties where we've got the experience. But I think when you're in that sort of exploratory phase and you're iterating and trying to find data that might be powerful or might not be, it is, for the new specialty, it is quite iterative. And so having that good relationship with the data teams has been really helpful.
And Janica?
So yeah, so I think it's kind of combining the expertise from different people, the clinicians and the clinical experience, but really the project management, Barty and colleagues really led, and that's so important because obviously us clinicians can get distracted, get moved, and keeping things on time and having that oversight, and then obviously the informatics and analytic expertise and experience of Factor 50 really putting the data in a digestible format for people to really act. So Ollie and others in Mark's team have been amazing. And we kind of built a very collaborative approach. And I think that's essential and complementary skill sets. From a clinical point of view, I think we have to be pragmatic. Steve, who's my mentor, and I have been talking about complications and risk stratifications for a year, maybe 10 years or more. But how do you deliver it in real life? I mean, you stratify, but it's also modifiable risk, but also making sure we have manageable risk in terms of the services we can offer people, and also being pragmatic in the rule set. So when we originally started, we ended up with 40 plus rules. And, this is not realistic because every clinician has their favorite. And I guess you need to drill down and think pragmatically, what do we have very good data on? What is objective data, not subjective data, but what is actually data that's there? And partly, looking at an objective, pragmatic data set, starting simple and then building and layering up subsequently is what we felt was the right approach, because also many systems don't actually ever translate to what we have done now, so cancelling clinics, DNAs, actually implementing it in routine care is what Steve and I and others have always wanted to do. So that is probably some important learning I would like to share. The mistakes as well. Yeah.
Thank you. And Janica, you've already covered this collaborative. Alongside the very collaborative approach and the quick building up of trust was the responsiveness of each side. And I don't want to underplay that. So when the Factor 50 team were providing feedback or had done some work, Janica and his team were incredibly responsive with that. And that really does become a very, very virtuous cycle in terms of the pace and the excitement. And for clinicians who've been wanting to do things, to be supported to do them in the way that we were, not just with Factor 50, but a big shout out to our city team, who also at that time, because it was COVID, they were supporting our organisation with a lot of project management skills. That was absolutely key to the success of this project. And I think it is really important, both as clinicians and non-clinicians, not to underestimate the criticality of project management skills in something of a project of this size. Bharti, I wonder if I could quickly put you on the spot. So Bharti was very much part of the initial team, and I wonder, Bharti, from your side of being on the city side of working with Factor 50 on this project, if you could just reflect on a couple of things that you think were really helpful in us being successful.
Absolutely. I think the key to success and key to keeping clinicians engaged was responding to the request promptly. So I think with the support we got from Factor 50 specialist analyst was key to this. So we had no time to lose when the request is, let's say, raised in a meeting. For example, how do we use this in clinic? How can you help me manage my clinic cancellation better? The turnaround time was swift, which kept clinicians engaged, and also we were up against a very big transformation program in the trust called EPIC. Basically, everybody knows that. That's no surprise. And this was more interesting because we were delivering what we were committed to do in our plans, and we at pace. So I think this whole triangular relationship between Janaka, the specialist analyst, and us, I think that was quite key to progress quickly. Sorry, does that answer your question?
Absolutely, that's brilliant. Thank you very, very much. Back to you, Mark and Janaka.
So next slide, I think, Mark, maybe.
Yeah, thanks, Jade. Thanks, Janaka. So just briefly, so everything we've done, we've talked about so far has been based on hospital data. One of the questions in the chat, was it Ruby, has been talking about sort of what sort of data. The left-hand side alludes to some of that. We can definitely explore that in more detail, Ruby, offline if you like, but essentially you need the cohort information and the appointments data. That's sort of your basic framework. And then what you overlay with that are the raw data that's going to inform the rule set. So in this case, it's things like lab tests that give you all the HbA1cs and the EGFRs, sort of the blood test results. There might be diagnosis codes, there might be admissions data, there might be PROMs if it's rheumatology. But that core foundation is the cohort and the appointments data, so you know which clinics are coming and when. So that's the hospital data. In addition, we all believed it would be more powerful. I keep thinking of it as a safety net. It'd be more powerful if we can bring in primary care data and other sources of data. So in London, they're blessed. They've got a big joined up data set called Discovery, or One London Leica. And so we've partnered with GSTT, got the application for that approved about 6 or 8 months ago. And we're just starting to bring in Discovery data into the platform. That is intended to be some other secondary care data and primary care, but it's mainly primary care data. But we're starting to see richer information on the patients. You know, it's picking up blood tests that are done in primary care or in other areas, and you just start to get more or fewer and fewer greys. So the greys of our color codes are where there's no new data, and they're starting to shrink. And in particular, we're starting to get more confidence around the greens, which is great. So that's about freeing up capacity. And then the bottom circle here is about patient provided. So I've touched on PROMs, which is patient recorded or reported outcome measures in the case of rheumatology, where that's important. But I also think medtech could be great, particularly in diabetes. So we're in a couple of detailed conversations, one very detailed conversation with one of the CGM, the continuous glucose monitoring. So I keep pointing to my arm, but the patches or the devices you stick on your arm if you're diabetic and want to be more constantly measuring your blood glucose, that would be a fantastic extra data point to start bringing into this. And so we're in really active conversations with particularly one of the providers. We're talking to a few, but particularly one, where we can start to bring that data into the safety net. So the vision is, essentially, can we build the best safety net around all these patients with as useful a data as possible, And then guess what? We're not expecting clinicians or admins to look in that data every day because that'd be too time consuming, but that's what computers are good at. So let's get the computers to do that hard work and then just present it in a really simple way, which might be just the 5 colours to start with. For every patient coming in, are they red, amber, grey if we've got no data, or green or super green? But the idea is that we continue to build a stronger data protection around all these patients. Thanks, Jade. Next slide.
Next slide, yeah, sorry.
I'll embarrass Janica with this slide, but on the left-hand side, it's just a bit of a list of where we presented the work that we've done. I think it's more just a measure of how rigorous we've been, particularly in diabetes, led by Janica. So been at a number of different conferences. There's been a paper published. We were also lucky enough to win a HSJ Digital Award earlier in the summer. Next slide, Jade. Just in terms of sort of trying to put a bit of sort of business case thinking about it, I don't know, we've probably got a mix of sort of transformation people, clinical people, other people on the call today. But at some point, every project's got to start to talk about, how does it pay for itself, or how does the effort get recognised? And we think there's four different strands. I think we all think there's 4 different strands here. So it reduces clinical risk, it releases capacity on follow-ups to see more new patients, and that particularly the way that trusts are compensated right now. Most trusts are on a block contract for follow-up, but on a tariff for new. So if there is a way to reduce follow-ups in a safe, rigorous way, we think this is it. And if you can reduce follow-ups and see more news, you can potentially increase the revenue in that trust. The third is at the overall sort of trust performance level, reducing your waiting lists. And then at some point, I suspect we'll talk about health inequalities, but we didn't set out to tackle health inequalities. Let me be open and honest about that. But what we found is, guess what? When you look at the patients that are red who need to come in, they over-index quite strongly on ethnic minority groups or on lower deprivation deciles. Particularly if you start to look at people with multiple long-term conditions and comorbidities, again, they over-index in those groups. So when we're using data to prioritise, it's much more likely to tackle health inequalities. And the more that we look at that across renal and cardiology, as well as diabetes and rheumatology, that story seems to be true. So that's kind of the right-hand side. And then order of magnitude, you just need to see about 3 additional new patients a week to cover the costs of the project. We don't need to get into too much detail now, but this isn't very difficult. This isn't a big IT project. It's something that's quite easy to replicate. Guys have done a lot of the hard work in the learning, but that's why we want to try and take it to other trusts. Thanks, Jade.
So just Mark, can we sorry, Jade, just to keep it just on that previous slide. Sorry, Jade, you're doing a brilliant job. The health inequalities bit did sit very close to my intentions, because what we often don't do across all of our systems, no matter how engaged or how much of a priority health inequalities are supposed to be nationally, very few of us cut our data and then look at the demographics of that, so ethnicity and deprivation. Ruby, you had a specific question about whether we have evidence of tackling health inequalities, and I'll make sure, Janica, could we just cover that when you come back in on the slides? Thank you.
So yes, I'll just cover that now. So when, as Mark very nicely explained, when we looked at our red flag patients, more than 40% were of non-Caucasian origin, and we looked at their postcodes. There were also patients who were in the most deprived, when you look at IMD, indices of multiple deprivation. And using this objective way, the red flag patients were disproportionately represented by non-Caucasian and living in poorer parts of London. And this, in my view, is a very fair and objective way of assessing inequality for modifiable risk. And I think I keep coming back to this, modifiability is key, bringing the patient forward, but also having an opportunity to intervene and prevent progression of disease or prevent complications. So this, as I think, as Dagny already said, we we didn't start off with that, but we knew, and I think all the clinicians in the audience know this. We see it every day. But when the data supports it, it also highlights to our colleagues and our peers why we have to change our practice. Because if we carry on as things were, we are actually potentially doing harm and not really targeting the patients we need to see. So it also is important to have this data to change people's views and practice. And I think it's very powerful, because the whole point is, how can we make things better for those that greatest need?
And when we talk about those at greatest need, just to be absolutely clear that if those patients are left and were the ones that were going to have an appointment the latest or have the longest interval, we know that access to healthcare, access to a clinician, whatever the condition you look at, for most of the diseases and conditions we deal with, will improve your clinical outcomes. And in improving those clinical outcomes, what we are preventing is unscheduled care, which in any system costs a lot of money, because you then start failure demanding. And that's just not good. And we tend to do this with some expertise within the NHS, and then we're surprised by the demand exceeding the capacity. So this really is transformation. When you start looking at these little bits, it's a simple system. It's not inventing any new rules. They are either there's national guidance around it or gold standard clinical guidance and acceptance, and then applying that in a way that doesn't build in systemic biases and institutional biases. So a lot of the green flaggers who are better educated, higher demographics, speak English as a first language, are very happy to pick up the phone and to demand an appointment. But we now have a robust way in which to assess this risk and to see this risk. And maybe we'll spend a bit more time talking about the visibility of risk. Thank you, Jade.
Yes, in terms of sort of moving the project forward, I think Janica or I could take this, but essentially next steps for the project, we've talked about moving into more specialties, we talked about bringing in more data. The other thing we'd love to do is work with more trusts, and so if there are other trusts out there, sort of diabetes and rheumatology, we're good to go. We can move very quickly with that. Like I said, in the pipeline, renal and heart failure are just coming up over the last jump, and they're really close. And so if someone's interested in heart failure and renal, again, that's imminent. And then if there's a new specialty, like we were talking about hematology last week with a different trust, you could alter that. It's fair to say that the trust has had a fair bit of recognition for the work that we've done, and so another trust wanting to pick up and run with a different specialty, we'd really love to work with you on that if that's of interest. The other thing I've just put at the bottom here is a lot of people sort of get the story but want to know how this applies to their trust, and so their cohort, they might feel like their cohort's slightly different. It might have a slightly different focus, slightly different scale, slightly different way of working. So the other thing we can do is just come in and do a quick exercise, a 2 or 3 month exercise, to essentially get hold of your cohort, hit your data, and essentially play out. We haven't actually shown the killer slide, but essentially play out the split, so we can essentially shine a light on your cohort and say, 15-20% are red, 15-20% are green or super green. Here's where they're falling, here's where they're coming in over the next few months, and just to make it come alive, because I think quite a number of people sort of like this story, but they want to see how it applies in their trust, in their organisation. We can come in and do that in about 2 or 3 months.
Thank you, Mark. And just to cover, I don't think we're covering it in any more of the slides, but the choice of additional specialties in addition to diabetes and rheumatology with heart failure and renal was really to start properly addressing multiple long-term conditions. So you will know that the group of patients, if you have a Venn diagram of these diseases, in the middle there are a cohort of patients who will be seeing 3 or 4 different specialties at various times for their scheduled care. And the idea is that we will develop this system of red flagging. There was a question again, I can't remember if it was Ruby or Sandeep, asking about how the red flagging within that would work. And at the moment, the way we would see it is each specialty would have its clinical rule set, that library, and those would then be brought together, and we would start looking at what patients who are super green within that, i.e. their care pathways can be changed. They can be virtual, face-to-face, or even longer in between. And then for the reds or the infrareds, we coordinate their care at the point at which they are seeing one or more of the teams in order to make sure that we maximise impact and reduce resources, both for us as a system in multiple appointments for the same patient, and for the patient and having to come in multiple times. And again, when we look at the demographics, so we work in South East London, it has the two poorest, highest deprivation boroughs, Southwark and Lambeth. For patients to take multiple days off to come in when they are, for example, on zero contracts has a big hit. And what does happen is then we get a lot of DNAs. Talking about DNAs, Janica, do you just want to talk about how we are looking at handling DNAs? Because we can apply this prioritisation, can't we, to both waiting lists and to the way in which we prioritise our DNAs. Janica.
Yeah, so when people do not attend, we are able to look at the DNAs, but also run the algorithm and have a more focused approach. So, you know, different clinicians do different things with DNAs. And, you know, historically, when I started doing clinics 15 plus years ago, we used to try and ring every patient to DNA, and some people answer, some people don't, some people do it. So now what we do is the algorithm is run on the DNA patients. And if they've had new data, that obviously scores them red, or there is no new data, we will prioritize the very important resource of our specialist nurses, our allied healthcare professionals, to really try and contact the patient and also rebook them sooner, so they get another appointment, the first next appointment. And also for people who are on waiting lists and undated waiting lists, so we have this undated follow-up where people are in this room waiting for a follow-up appointment, and we were able to use the algorithm to really target 500 plus people who are waiting for a date for the appointment, stratify them, and then ensure that those who scored red would be the ones who are right at the top of the list, rather than you know, the other methods we had. So it has made a big difference in my view. Also targeting those health inequalities and inequities, because as Dagny very eloquently said, there is a population within our service who will always contact us and demand things, but those often at highest need and highest risk don't know and are also unaware of their risk as well. So we did a small exercise where we called 50 green patients and 50 red patients, just to see how people would feel, specifically the patients who are super green and green, if their appointment was pushed back. And, you know, 90% of people were comfortable with the appointment being pushed back, because they knew why, because often we don't communicate very well in the NHS when we cancel things or change appointments. They get a text message and another one and another one. We explained why, but also we ensured that they had the contact details and that we had looked at their data. There was nothing alarming, but if there was anything, they could contact us and have the information. So I think that communication to patients is also an essential piece of how we can adapt the service to be fairer, but also more efficient.
Thank you. And I'm just going to cover a question from Atul Garg about this working really well in anaesthetics and pre-op clinics. You are absolutely right, Atul. And what I didn't say at the start was when Factor 50 made that very generous offer to us during the Omicron wave, and actually the offer came to us and our first meeting was on the 23rd of December. I did approach our director of surgery at that time to say, look, this could work really, really well for those lists that we're cancelling, and there's a lot of intense senior clinical consultant time, as those most of you on the call will know, to look at various bits of data with patients to prioritise them. But my reflection of that is that surgery were just overwhelmed. If you remember, there was a lot of media interest in operations being cancelled. At that time, people were slightly less interested in all of this ambulatory other scheduled care that we had to deliver as the NHS. And so they stepped back from it. Some of you on the call will also know that there are some huge data analytic players in the area of let me help you prioritise your own operating list. and that sort of work very specifically. The systems tend to be fairly expensive and tend to not be bespoke. The beauty with this system is that it is absolutely clinically driven. So that clinical intent library has had, when we show you the rule sets, they as Janica says, they've gone from 40 down to 6. But that synthesis of those clinical rule sets has taken 10 of our senior diabetologists to have those discussions, because we all as clinicians see risk slightly differently. And that is the other transformative power of DLP, is that you reduce the variation in which clinicians, irrespective of how good and how expert they are, will see risk. And that for me is really, really important transformation. That is using data insights to drive how we make clinical decisions. Mark, do you want to just address, Faye has put a query here about physiotherapy clinics and the use of that. So would you just like to cover application outside maybe the traditional clinical specialties we've talked about?
Yeah, absolutely. Faye, thanks for the question. Dagny, thanks for stitching me up. I know very little about physiotherapy, but Faye, essentially our framework, I think, could apply in the same way that I think was Atul was asking about sort of pre-op and anaesthetics and surgery. I think our specialty is in engaging the clinicians, so figuring out what it is you guys want and then having that conversation. And if you were able to describe the sorts of things you'd be looking for, how would you want to prioritise patients coming back? You know, who would you give the greatest focus to? Who would you be happy to come back on the 12-week type rebooking rather than the 2-week rebooking? If you could provide that clinical expertise, which I'm sure you guys could, then we would work with you to go and find the right data and then to robustly score it. So that's what we're good at. We're pretty good at the data and being responsible for the scoring. We'll take responsibility for that, but we rely on partners to provide the clinical expertise.
And just to add to that, Mark, there have been conversations, haven't there, with, you know, community care not delivered by doctors. Diabetes care is very, very much a multi-professional.
Yeah, so we think another way of extending. We think another way of extending this is definitely, you see a lot of patients sort of sloshing around between primary care back into secondary care. Sometimes ICSs or communities have, ICSs or counties have community hubs as well, which sometimes sort of that level in between primary and secondary. So we think there is a real opportunity to work with ICSs, particularly on the coordination of care across those various levels. So we'd be open to exploring that as well. Yeah.
Thanks, Mark.
Thank you. Back to you, Janica.
Dagny, the next slide just sort of tees up Q&A. I don't know if there's broader questions. The chat's been pretty successful, but
it has.
Do we want to start presenting? I don't know.
Yes, why don't we take that down? And I'm wondering, Mark, I'm going to put you on the spot. We didn't show the killer slide, and I think that whilst we're chatting, if you could just maybe put that slide up.
It's in the appendix, actually.
Fantastic. So let's just show that slide.
Putting it back up.
So Janica, if I can come back to you while Mark's doing that to say what was going back to the 23rd of December, and again, I always say when we're doing these presentations that the Factor 50 team were really committed to turning something round over that Christmas and New Year period, which they did incredibly successfully. And with Janica giving up his time over that, what was a very stressful period really for all of us working in healthcare. What, Janica, do you think was one of the key success factors for you, or what excited you about the work? Because there was a lot of additional time and commitment that went into it in the start to get that momentum going.
So I guess we've been talking, as I said, for many years or decades about risk stratification, using the data we have to do better. But we saw this as an opportunity to really work with experts, and also the quick turnaround time with Mark's team, Ollie, and others, where we could see the results emerging very quickly. Obviously, we're quite advanced stage, but from refining the rule set, running the initial validation, we could actually see that there was a potential for clinical impact, which is very exciting because there are lots of projects where you have endless meetings and nothing much happens in between the meetings, or new things are planned. But here, I think what was exciting was within the first few weeks, we could see the results emerging and the potential. Even if there was another wave, that we could do a lot better than we had done in the previous 2 waves in terms of, who do we see in my clinics? How do we prioritize the right patients? How can we ensure that the limited resources with people being, moved to other areas, realigned, repurposed, reallocated of clinical work, how we could do that. So that was really exciting. I'll pass on. I don't want to take away from the killer slide, Mark. So I'll let you take control of this. This is what we really kind of saw the potential, I guess. Yeah, this is the slide.
That's why we're both laughing, because we call this the killer slide, but this is data from February last year, so no apologies, we've kind of kept it in its original format. But what you've got, just so I can explain it, we've got about 4,000 patients in this particular definition of the diabetes outpatient list. They're all patients who've been seen once, they're on the follow-up list. And on the right-hand side, you've got the distribution of when they're next going to be seen. So the data was cut at the start or second week of February 2022. So if you look at the distribution of when they're going to be seen, that's kind of what you'd expect. There's some in February, the most popular month's March, and then it tails off over the year. And some are being seen out as far as 12 months, which might be fine. And then, I can't read it, but from memory, it's about 500, 600 that have got no dated follow-up. So that's the bottom bar. So they've not got a date yet for their follow-up. So that's just what you might be able to see from your own data pretty quickly. What we did, and this was the first application, so the numbers have shifted since, but what we were able to then do was code up, we call it Janica's rule set, but the GSTT rule set, and then apply it to the data. And so what you see are the distribution within each monthly group of the reds and the greens. So you see a pretty even distribution across the whole picture of reds and greens. And so if you look out, there's about 250 patients who are red who are not going to be seen for at least 3 months. And in and of itself, that's just stressful, right, for the trust. The trust's already pretty busy. Just telling them there's another 250 patients out in the future who you really should be seeing is just adding work. The bit that gave us a little bit of hope was that there was about 200 who were greens who were going to be seen in the next 3 months. And so this is why we call it the killer slide. We struggle to get through a presentation without trying to reach for it, because everyone once they understand it just gets it. We're essentially shining a light on the cohort of follow-up patients and helping everyone see where the risk is, but also where the relative stability is. And so I know it's not as easy to turn it from this to, let's immediately swap those, but this is what got us excited. And we sort of had this in sort of month 2 or month 3 of the project, which is why it was exciting, I think.
Thank you very much, Mark. Sonali has got a question about applying it to ophthalmology, and we could also discuss a little bit about a cardiology experience. But before that, Atul, could I get you to come in? I nominally answered your question about preoperative assessment, but I wonder if you want to address a more specific question to any of us.
Thank you, Dagny. It's just our reflection. I work at Walsall Manor Hospital, and in our ICS, you've seen a lot of on-the-day cancellations. I also happen to be the QI lead for the trust. So we have a QI project going on currently to try and reduce on-the-day cancellations. And one of the major factors for on-the-day cancellations was poor pre-op assessment and not changing the modifiable risks. So diabetes nationally has been recognized as one of those modifiable risks for surgery. And if you did proper pre-op assessment, early identification of the patients, brought the HbA1c down, it does show length of stay reduction, etc. So this kind of data led prioritization would be amazing for pre-op clinics, where it's not on an ad hoc basis or the pre-op nurse actually putting in patients to be seen by the consultant. There's not enough consultant capacity for pre-op for then the patients to actually have their modifiable risk seen. I think talking to a few diabetes specialists around the region, even the diabetes clinics and the specialist nurses don't have enough capacity to see all the surgical waiting list patients and change a modifiable risk. I think there was a recent national webinar on IP3D, the perioperative care of patients with diabetes. This is part of the things that they were mentioned, but they did not touch on data in that. So, but I think it will be fantastic for this to be in use in the pre-op space. Sorry, I have no questions.
No, thank you, Atul. That's really helpful to sort of provoke just more discussion, really, because I think there is, although when I said initially I was looking at just prioritization of elective surgery as such, you are right. There is something about using those modifiable risks to ensure that when we are operating on a cohort of patients, we know those who are red flagging for modifiable disease metrics and those that are green, and prioritizing the making sure that as many people as green as possible is something to think about. You made another point in that the nurses then do that first level of screening, and then they have to refer to a more senior clinician or to a doctor, and that's part of the beauty of this system. It is that we can, in a digitalized way, apply that clinical expertise in the form of the rule sets to help that prioritization. So really, we can apply it to any disease, any area. Janica, do you just want to come in on that, using that diabetes example and elective surgery, please?
Yeah, so it's a very common problem even at GSTT, and it's actually standardizing the criteria for referral to valuable diabetes slots with diabetes specialist nurses. And I think you've hit the nail on the head, Atul, that you need something like this, because we get referrals for different types of surgery, for different levels of HbA1c, some modifiable, some not modifiable. So if you have 4 diabetes nurse slots this week to optimize someone, how do we ensure that those right 4 or 5 or 6 patients are booked into those slots? And that's where data with a rule set, where you define the rules, can really improve efficiency and prevent a lot of unnecessary cancellations. So I think diabetes, is one of those situations where if you look at HbA1c as a modifiable risk, you can really focus on those and also ensure that the red flag patients have enough time to improve their glucose control if the operation is elective, to make sure that they're in the right level of control pre-op, and then you prioritize the lists accordingly, without just doing it as a cancellation the week before, which happens everywhere, where people come in, they measure it, and then the patient has to wait 9 months, etc. So I think it is a useful model, an opportunity to use data very efficiently.
Thank you, Janica. And Atul has put a thing back in the chat about HbA1c tests being patient guided. So that's the patient initiated follow-up, which takes. Janica, do you just want to address that?
Yes, yeah, exactly. So you can, as Mark alluded to as well, remote monitoring we use a lot in diabetes. Patients can come to local hubs, have a HbA1c test, have a blood pressure check, have a kidney function test in local community hubs in South London, and we will have access to those results. So if they're unable to do a home test, they can actually go to a more convenient location to have these bloods, which come to a central lab. And that's the way where we actually drive patient-initiated follow-up in a more efficient way. But yes, that is possible. And also, GP appointments are incredibly difficult to get. And this is another way where I think the secondary care really needs to take ownership, because primary care is drowning, and we can't say, oh, do HbA1c, do a blood test in a letter. I get irritated when my registrars do that, because there's no way that they're able to do it. We have to also help our primary care colleagues and communities, and this is a more efficient way of healthcare delivery.
Absolutely. Modern healthcare delivery, rationalizing the resources, and really it is about that communication, isn't it, between what we traditionally see as primary care, secondary care, acute care, scheduled and unscheduled care. Thank you very much, Atul, for raising those really important points. Mandy has put something in the chat. Mandy, please do give us your contact details and we can be in touch. Oh, you have done. Thank you very much. John, can I come to you, because Mark feels he's been under pressure with questions asked. Your reflections, you've been aware of this work, you've been following it, we've done several IHSCM events. Do you have some reflections on the project itself and maybe the sort of framework within which it's occurred?
Yeah, I'm very happy to comment. I mean, first of all, it's clearly wonderful work, and I think Mark's right. I don't think there is, and he'll forgive me here, I don't think there's a huge amount of breathtaking intellect to this. I think what Mark and his team at Factor 50 working with you guys has done is you've just picked out the key data, and Mark and his team have put it into a usable and visually very compelling methodology, and that's lovely. You know, the NHS is awash with data, but we're generally fairly poor at using it intelligently, and hats off to the discovery data team as well, because you know that is the real enabler here. The other thing I'd like, if I may, just to reflect upon is clearly this is good. I mean, one only has to listen to Janaka talking about the transformative effect it's having on his clinics, and yet it's only really at GSTT at present, and we are just so poor at sharing good innovative stuff across the wider NHS in all of its different forms. And I just wish we would be able to do this you know, more effectively, more powerfully, to make sure that all other trusts were instantly aware of the fact that, gosh, there's something going on at GSTT that's having profoundly positive effects. And I'm not sure how we do that. My worry would be that there's another 200 teams of diabetes specialists all trying to invent their own wheel, you know, for how they do a similar sort of a thing. And yet you've got it. It's here, you know. No doubt that Atul will be in touch very shortly for Walsall to be having a good look at it. And that's the beauty of gatherings like this, to be able to share the good stuff.
And thank you very much, John. One, for that opportunity, and two, for GSTT to be part of the London Regional Hub for IHSCM. So on that dissemination, maybe we should spend a little bit of time, because we have, between the team and especially with Mark and I, spoken to several teams who have been very, very interested, because it is a compelling story. And not only is it a compelling narrative, but we have the data to back it up, the real life data, and the teams to back that up. But there's often been this issue about how we're going to pay for it. And the two things: one is how we're going to pay for it. Two is how does it integrate within our either electronic or digital health system, care records, and or if we're transitioning to something else, how are we going to deal with that? And that's why Mark had that, you know, what do you need to do in terms of seeing three new patients that you release capacity for, and that being the compelling resource case. You are hitting those 4 areas. And again, I come back to this issue that we all talk about inequalities, but actually we don't have pounds and pennies on inequalities. We say it's a priority, but it doesn't directly translate into pounds and pennies. So you need to use what is now the current operational delivery plan, where it is very clear that you are being mandated, in inverted commas, to see more new patients in order to get on top of that backlog of healthcare that we need to be delivering across the system, and less of the follow-ups. And in that also to say that when we as clinicians very happily say 3-month follow-up, 6-month follow-up, 12-month follow-up, there is no clinical data to follow that. That is entirely the fact that it's just easy to say 3 or 6 or 12 months without really any data to back it. What we are doing is also trying to transform the way in which we see patients for follow-up in a more intelligent, data-driven way that has reduced unwarranted clinical variation from individual clinicians. But Mark, just in terms of the value case and how we've had to work through, could you just share some of the insights from conversations that the teams have been having?
Yeah, sure. I mean, I don't want to talk too much about business case. Each trust, I think, will come at this from a few different angles. The support I think we feel like we've had through the operating guidance that always seems to come out on Christmas Eve every year, but the latest NHS operating guidance does tell a story about real pressure from sort of the central team to squeeze down the number of follow-ups that each trust is doing and try and focus more on the news. I think that's why the follow-ups are being set targets to reduce by sort of 15-20% over the next 2 or 3 years, and they're on a block contract, whereas the news are still rewarded on tariffs. So I think NHSE, there might be folk from NHSE on the call today, please jump in with more information. But what we're seeing is that sort of carrot being dangled to try and incentivise the trust to see more news. So we're sort of, from our perspective, we're leaning into that to try and, that does align with the story. It does align with what we've developed. I don't want this all to be about business case, but there's definitely something there. I think more fundamentally, I think we're saving the NHS a load of downstream costs, because diabetes and a bunch of these long-term conditions, if they're not managed well, have real patient impacts. I mean, Janica and the team can talk way better to that than me, but foot complications and amputations, or eye complications, or impacts on subsequent, I think it was Atul talking about, other impacts on the health system, whether it's people not being actually ready for operations or surgeries and different things. Diabetes is a hugely expensive problem, and if I think what we've developed collectively, helps trust to sort of get on top of that. It's just hard from a business case perspective to potentially put your finger on that and say, and we are over time gathering evidence so we can say how many A&E attendances and things we might have avoided, or how many complications we might have avoided. That stuff just takes time. But I think that's the real benefit. If I was not just talking to the finance folk, I think the real benefit is really helping these patients. That's what has got us really excited when Janica and the team brought in these 130 before Christmas and said 40% have avoided clinical harm. That's awesome. That's amazing for patients, and that's also real downstream costs that the NHS has avoided. So I think that's probably the biggest lever. It's just hard if you're trying to put together a business case, it's sometimes hard to just put your finger on what that is. And so we've looked towards the operating guidance, which is also supportive, because it's that fixed price essentially for follow-ups and extra tariff in news. So there's a way that it can pay for itself through that, but I wouldn't want to lose sight of the bigger advantage, which I think is the real patient one, but connected to a cost saving as well.
Thank you very much, Mark. That's really helpful. And I suppose I wanted to highlight the added value in terms of not necessarily the business case, not to turn the clinicians off, but to say, if you're sitting there thinking, oh, if I need to access some money, how am I going to do that? That is part of what we can help you work through. I just wanted to reflect on the things that we often talk about that I think were also quite important in delivery of this project. So I've managed that getting the right teams together. There's that working together, understanding each other and being responsive to each other, which has been absolutely critical in the pace of delivery of this project. And then there's been the leadership, both from the analytical side, from the clinical expertise side, and then from the trust side, just because there are always challenges. There are always people who don't think it's a good idea at the start. So Janica, just maybe you could just tell us a little bit about those first few meetings when we took your intended library at that time to the wider colleagues, the diabetologists at Guy's and St Thomas's. There are a lot of them. They're all very expert, and that agreement and understanding that we needed to rationalise how we saw risk, and maybe that I think it would be quite interesting for those on the call.
Thank you, Dagny. So I think, as you said earlier, different clinicians have different thresholds of risk, and it's often very subjective. As clinicians, you often only remember the disasters, and you kind of have a bias over time, which builds, and also people, even in one speciality, can be stuck in a silo where they see the same patients or the same type of patients in the same clinic and follow a routine, as Dagny said, 3 months, 6 months, 9 months, 12 months, it becomes a habit. So we started with some rule sets which were nationally recognized for prioritization of high-risk people with diabetes. And then we sat down with our colleagues and looked also at what data we had accessible, which was fit for purpose, because there are lots of rules out there, but you may not have the data to assess the rules or the criteria. So our initial conversations was really gauging people's views of the pragmatic slim down risk, but also we did a couple of exercises, which I think, Dagny, you were there, where we went through cases with a multidisciplinary team of consultants and nurses, and actually went through cases and said, do you think this is a red list patient? Is this green? What would you do different? And, this is very insightful. They took a very long time and highlighted the importance of a data-led approach. But, it really was important to get the buy-in of everyone. And there are some people who may not change, as we all know, but also I think it's the potential benefits and the reduction in harm was really important. So I think I don't know if that answered your point fully, Dagny, but it was really about having a collaborative approach, a multidisciplinary approach, because our clinics are multidisciplinary and different people see different patients, but also bringing people out of their comfort zones. Because, if you do one type of clinic for the last 15 years, you may not appreciate if the kidney function has dropped by 20%, this is a bad thing, or vice versa. So I think it's about getting people to buy in, and that's important. And over time, I think we've made significant progress. For example, in our type 1 diabetes service, the data Mark showed, we had PIFU rates of less than 5% this year. But since Mark's approach, it's gone up to 25% in the last 2 months. And there's room for more improvement. So and those are probably the toughest clinics to change, because everyone was coming back at 3 to 6 months. And that's an example of change and motivation to change.
And transformation, isn't it? That is the crux of transformation, is those little changes that we're making that then, when we apply to the system, really make a difference. First and foremost to the patient, but also to the staff delivering care, because they're seeing patients who need to be seen and who they can help in that seeing. So really, really important. Thank you, Janika. I think that the other reflection, and maybe we should highlight that, is the time for a consultant to assess the risk of a patient on average. When we did the focus group with the consultant diabetologist, was between 20 to 25 minutes. And what we haven't done and played on is the fact that we now save that amount of senior clinical time in needing to prioritise these lists, but we're also doing it in a way that is just more robust. It doesn't have that clinical variation. And the third thing I wanted to say was what struck me facilitating the group of diabetologists was that when the risk became apparent to them, they wanted even more data and more data, whereas previously we had no data on these patients to inform any of the decision making. But that, again, it is the clinical beast that we are as clinicians, especially so as medical clinicians. So that there is some really important learning. One other thing I do want to say is that in a clinic, when you have your patients flagged, and this is the admin staff, the people who are running our clinics, are just as bought into this system as we as the clinicians delivering it are, then you are able to also allocate for clinicians who may have slightly more junior colleagues in clinics. You are able to allocate and guide the care of patients when you're not directly seeing them in a much, much better way. And that, again, is much more robust, so that the senior most clinician may choose to see the very red flaggers or the infrared flaggers. The others may choose to see the more green patients. The key bit, which we hope we will be coming back to you to talk about in terms of transformation and change, is using patient-initiated follow-up or feeding patient data synchronously and asynchronously into the system to enable us to finesse our data-led prioritization even more. So, Mark, I'm going to come to you for your final thoughts, and I'm going to ask if anyone has any questions in the group, if they could put their hand up while Mark and then Janica are giving us their final reflections.
I mean, I'll just keep it very brief. Thanks so much for your time, everybody. It's been great to share some of the story. I think the chats work really well. So Jade and John, obviously the way you've sort of set this up has worked really nicely, but I think the way that the audience, the rest of you guys, have engaged today has been great, because you don't want to hear from just Janica, Doug and I the whole time. So the fact that the questions have come in, and I think the chat format works nicely. So thanks for sort of taking part in it. A few of you have left your contact details. I'll probably just drop you a one-line introduction. You can choose whether you follow up with us. My contact details are in there as well, so feel free to ping me a note. But thanks for the engagement. It's been good. Appreciate it.
Thank you. Janica?
Yes, thank you very much for hosting us. I hope it was useful, and thank you for the very interesting questions. And also, I guess, I think there's huge potential to be applied outside diabetes. And I think Dagny's comment about multiple long-term conditions. And just to kind of finish off, we've done some work across cardiology, renal, and diabetes, and we've identified 600 plus people attending our clinics. And it's that comment Dagny made, which clinicians could see the patients more efficiently. There's a lot of DNAs in the people who have lots of appointments. That's not going to come as much of a surprise, but actually using data in a very powerful way across disciplines is really, I think, another opportunity to move beyond just silos of diabetes, because as in chronic conditions, they cluster together, and these are the patients with the highest need, but also the highest burden of NHS costs. So there's huge opportunities across long-term conditions, but multiple long-term conditions, using data to guide efficient and fairer healthcare delivery.
Thank you very much, Janica. So coming up in future, we will be hopefully presenting back to you our rheumatology, renal, cardiology, and hopefully, very excitingly, the multiple long-term condition management as well. I did have one final point I wanted to make. Many of you will be working within organisations that are either have recently launched electronic health records, or about to. So Guy's and St Thomas's were about to have the largest Epic launch in the NHS on the 5th of October. I say that with slight palpitations, but that provided us with some challenges. But actually, in the longer run, having these data clinical libraries, I think, will really help us transform that bit that Janica has just highlighted, that crossing across specialties and doing the right thing for patients in a timely manner, so they're not coming back for multiple blood tests or investigations or interventions. So some really exciting things. If you're worried about a new electronic healthcare record system, but you're really interested in this work, please do be in touch, because we have first-hand experience of that, which we are also very, very happy to share with you. So I'm going to go back to John, because he's going to finish us off on a very high, and say thank you very much to my colleagues, Mark and Janica, and to all of you on the call who have been interested. We will pick up on those email addresses, but please do email us as well, and I'll pop my email address into the chat whilst John closes this session.
Thank you, Dagny, and full credit to you. You know, off the back of a heaven knows how many hours shift, for you to appear and lead this so compellingly. Bravo to you. I don't think many of us could have managed that. So thank you for that. Yeah, thank you to Janica and Mark as well. And it's interesting, I'm just looking at the people who've been in the audience or are in the audience. We've even got people from the world of mental health and so on. And again, I'm sure that this could be applied across that sector as well. So yeah, come one, come all, and do please contact Mark or myself or Dagny if you'd like some more information. We would be delighted to spread the good news here far and wide. But for today, thank you so much, everybody. Dagny, go and get your head down somewhere. And for the rest of you, enjoy the rest of your week. And thank you for the great work that you're all continuing to do. Bye-bye.
Thank you, John. Bye-bye, everyone.